Welcome to TRIO Maryland, the virtual transplant journey. We look forward to a program filled with great information and takeaways for everyone participating. To open the event, please welcome Marty Marin, President and co-founder of TRIO Maryland, and Charlie Alexander, President and CEO, the Living Legacy Foundation.
Good morning, and welcome to TRIO Maryland's first virtual transplant conference. And we are so glad to see all of you here today for this educational event. I am Marty Marin, the president and the co-founder of the Maryland chapter of TRIO, which stands for Transplant Recipients International Organization. I am also a liver recipient, November 2009, from the Johns Hopkins Hospital. And I will forever be grateful to my donor for this second chance at life. After my transplant, I started volunteering at the Johns Hopkins Hospital and at the Living Legacy Foundation. And it was during this time that we were able to establish the Maryland chapter of TRIO. Our mission is to connect transplant recipients with one another, to provide education on transplant topics, and by offering non-clinical support, we complement the services of our healthcare professionals. We offer monthly educational meetings, and we have hosted 5 in-person conferences over the last 8 years. Please check us out on our website at www.triomaryland.org. And now for the thank yous. I would like to thank the TRIO Maryland Board of Directors and Drio, our web hosting company, for all that they did to create this event. I would like to thank our partner, the Living Legacy Foundation, and our hospital partners, Johns Hopkins Hospital, and the University of Maryland Medical Center. I would also like to thank the presenters for all their time and for sharing their knowledge on these very important transplant topics. We have wonderful sponsors that are involved with our transplant community, and we wouldn't be here today without their support. Thank you to all our sponsors. Don't forget to check out our sponsors and their websites. You'll find them on our sponsor tab on our registration platform. Thank you again, and we hope today is informative, educational, and helpful as you make your transplant journey. Good morning and have a good day.
Hello, my name is Charlie Alexander. I'm the President and CEO here at the Living Legacy Foundation of Maryland. I want to welcome all of the TRIO members to this event and just say a few words on behalf of the Organ Recovery Program serving most of the state of Maryland here. The TRIO has been a valuable partner of ours for years. There's no more compelling message ever than to hear those patients and their families who've been impacted by the gift of organ and tissue donation. You are our great stewards, you're our great spokespeople, and we get up every day and come to work in service of you and your families. Now, the Living Legacy Foundation is the organ recovery program here, again, working most closely with Johns Hopkins Hospital and the University of Maryland Medical Center. So we're working with families who are arguably going through some of the worst days of their lives, faced with the prospects of saying yes to organ and tissue donation. And we are thinking of you every time we sit with those families, advocating for our waiting recipients and serving our donor families. So thank you for what you do. Thank you for the courage it takes to be an organ and tissue transplant recipient. I have a longtime friend of mine all the way back to days of middle school who received a kidney and pancreas transplant, and she reminded me every day following her transplant that being a recipient isn't for sissies. And I watched her work hard to be a perfect steward of that gift and honor that donor family. And to me, that's humbling, and that really defines why we do what we do. So thank you again for being a part of this day. I hope you learn a lot and you can share a lot with others going through the same transplant journey that you're going through. And again, best wishes for good health and a great 2021. Thank you.
What a great introduction and a great way to kick off this 2021 event. TRIO Maryland is excited to be bringing you this conference virtually. A few housekeeping items before we begin. This webinar is being recorded. Recordings will be sent to all participants after this event. There will be a general meeting room. Chat face-to-face with other participants. This Zoom room will be open from 10 a.m. to 12 p.m. Eastern Standard Time. Link will be available in the chat box at the end of this session. Support. If you need support, please text 410-635-0229. Please use the Q&A feature to ask questions, which will be answered by the presenter at the end of the session. And for the chat box, please use this chat box feature to communicate with other participants. This is a webinar format and you will not be able to see or hear other attendees. One last reminder about your individual schedule. Please remember that the sessions you registered will all have separate Zoom links. You can log in to the links 5 minutes before the session starts. Again, if you need support, please text 410-635-0229. The first session today is preparing for your thoracic transplant. Please post your questions in the Q&A tab, and we will share this with the speaker after the presentation as time allows. Our speaker, Dr. Polly Shaw, is the Medical Director of the Johns Hopkins Lung Transplant Program. She is a pulmonary and critical care physician and an expert in the diagnosis and treatment of advanced lung disease and lung transplantation. Welcome, Dr. Polly Shaw. Please take the floor.
Thank you so much, Hazel and Charlie and Martin, for such a nice introduction. Can you guys hear me okay? Perfect. Okay, I will go ahead and continue. I'm just going to share my screen. Everyone see my slides okay? Yes? Okay. All right, well, today I'm going to talk about thoracic transplant, and that includes heart and lung transplantation. We'll talk about the indications for heart and or lung transplantation, some of the risks, benefits, and outcomes. I'm sorry I can't see all your faces today, but in the past, folks who've attended TRIO are often patients who are in the process of going through the transplant evaluation. They might be on a wait list or considering transplant. And so I'll try to touch on all of those, but please feel free to ask your individual questions, and we can personalize it and tailor it as per your interest and needs. I'll talk about both heart and lung kind of side by side and compare and contrast. As there are certain things that are common to both transplants, and there's certain things which are unique to each. And so we'll do this sort of jointly in parallel. So we'll start with a lung transplant. A lung transplant is usually a last resort treatment for someone with end-stage lung disease. It's surgery to replace one or both diseased lungs with healthy lungs from a donor. The donor lungs usually come from a patient who's usually with brain death, but it can also be with someone who's had a cardiac death. And the size and the blood type need to be matched as close as possible to your size and blood type. Here's a quick picture of a donor lung transplant. It can be single or double, and that often depends on an individual's individual situation, the type of lungs they would benefit the most from, age, and their ability to tolerate the surgery. Heart transplant is surgery where a diseased or failing heart is replaced with a healthier donor heart. It's a treatment that's usually reserved for folks whose condition has not improved enough with medications or other surgical procedures to help the heart function. Can be done from infancy and pediatrics or through adulthood. And the procedure is kind of shown in a schematic below, where the diseased heart is removed. The donor heart is then reconnected to the major great blood vessels, and then it circulates and pumps blood through the body. Over the past 2 to 3 decades that we have been doing both heart and lung transplantation, On the lung transplant side, worldwide, lung transplant procedures have actually increased as we have learned to better find healthy donors, help people with complications get through the procedure. And so in general, lung transplant procedures have grown, and the majority tend to be double lung transplants. Heart transplants have been pretty stable. They've had a little bit of an ebb and flow. And part of that is due to the fact that some of our patients who previously needed a heart transplant may be able to be supported with other mechanical assist devices or support devices, but has sort of picked back up again as patients live longer and we're able to better make good use of the heart. So to be considered for either, so you need to have a condition for which we think transplantation is effective. Typically, both candidates for heart and or lung would have a severe condition that is progressive and is no longer responding to medical treatments. Candidates must be willing to accept the risk of the surgery and be willing to undergo lifelong medical treatment because they will need to be on medications to prevent rejection, and then to be physically able to undergo the surgery, recover from that surgery, and tolerate the medical treatment that will be necessary. We'll personalize this to lungs for a minute before going back to the heart. The types of disease that we often will get referred for include things like COPD or emphysema. Most common condition for lung transplantation is someone who has pulmonary fibrosis, and some folks will often have other variations of pulmonary fibrosis, kind of all grouped under this umbrella of interstitial lung disease. Some folks may have a condition called sarcoidosis. Some of our pediatric and young adult populations were born with a condition called cystic fibrosis, and they may survive into adulthood, but still are not quite at the point where they're living a normal life expectancy. And so we do get a portion of patients that have CF. It's an airway disorder, and inside the lung, it actually looks like the one right below it, bronchiectasis, which is sort of another airway disorder that then causes the lungs to get scarred and filled with bacteria. The other two I'll mention that are kind of round out the majority of lung transplant candidates would be something called pulmonary hypertension, a condition where the blood vessels in the lung get scarred down and narrowed and no longer can actually circulate blood the way they need to, and some rare conditions. This one below, lymphangiomyomatosis, is something where there's a smooth muscle that kind of gets a little bit overactive in the lung, and it keeps the lungs from actually doing their job properly. Obviously, not every patient who has one of these conditions needs a lung transplant. And in general, patients that are short of breath with kind of just everyday activity or requiring oxygen or maybe candidates for lung transplantation. If the lungs are not expected to function well for over the next 4 to 5 years, that's probably an appropriate reason to think about, or at least be referred to ask about lung transplantation. And for each of these conditions, the timing of transplant really depends on how fast the condition is progressing, because each of them progress at a different pace. On the heart side, there is a weakening of the heart muscle, and that's typically called cardiomyopathy. And that's often one of the most common pathways that may require folks to get a heart transplant. This can happen due to coronary artery disease, heart valve disease, a congenital heart defect. Other reasons that might lead to a need for a heart would be a dangerous heart rhythm that's just not being controlled appropriately with medical or other treatments, or failure of a previous heart transplant. And again, not everyone with each of these conditions needs a heart transplant, but if there are being repeated hospitalizations for heart failure, if they need a mechanical or ventricular assist device to support the heart, and if they are requiring increases doses, complexity of medications, if they're on intravenous medications chronically, that's someone who really has a limited quality of life and may benefit from a heart transplant. The final, it kind of speaks to the function of the heart and some technical terms that often our cardiologists will use to kind of help sort the timing of lung transplant and the right timing. For both heart and lung transplant, life expectancy and success rates have improved. Under both transplants, about 90% survive through their first year, and they have a successful recovery. regardless of that initial success, lung transplantation survival is still not quite the same as it is for other organs. It's about 6 to 7 years as an average, but we have had patients that we have followed now for 15, 20, 25 years. So it really is dependent on the individual. Heart transplants actually last a little bit longer. Once you get through those first initial months, things do settle out and there's less rejection. And so the average survival life for heart transplant is actually close to 10, 11 years. Both procedures are intended to improve quality of life, with the majority of patients being really satisfied with their decision, getting back to doing their daily activities, the things in the life milestones that they wanted to achieve, really without too much restriction, but with close medical follow-up. We'll talk about risk and complications. There's always risk. It's a big surgery. And certainly there's some long-term risk the lung or heart may not work well as expected. And this is because these are foreign organs. So your immune system can certainly cause rejection. And even though you will be on medications to reduce the risk of rejection, we don't fool the body 100%. And so we'll talk a little bit later in the talk about what we do to look for this and screen for this and prevent rejection. On the heart side, there can be some rhythm and valve disorders. On the lung side, there can be some infectious complications because you breathe air and you have a weakened immune system in the process. And then the medicines themselves, while very effective at preventing rejection, they're not perfect medicines. And so there are some side effects that can over time lead to complications, including kidney injury, infections from that weakened immune system, digestive disorders, and even cancer. So again, as I mentioned previously, the folks that come into this session have been in the process or have been through the evaluation. And so those of you that have know that it is a pretty comprehensive process. Often you may be referred by your cardiologist or pulmonologist before you are critically ill. Although sometimes we get those referrals that happen suddenly, and then we are seeing them for the very first time while they're in the hospital. But if you're referred as an outpatient, typically the evaluation we'll take our time with it, and we'll really get to know you, get to know your family, get to know your health over the next several months. During that initial consult, typically your cardiologist or pulmonologist will sort out whether this is a good option for your specific lung or heart disease. And they'll also advise if there's known conditions that may affect the success and the good recovery after transplant. We then do a deeper dive into what we kind of consider the formal evaluation at most centers. And that's typically a more head-to-toe evaluation to look for things that may not be known about your health. This could include things like CAT scans, blood tests, stress tests, swallowing, and that's often personalized based on your individual disease, your age, the things that we do know about your health, and the things that we commonly see with your actual heart or lung condition. You get to meet the entire transplant team because it takes a village. So that includes our surgeons, our nurses, coordinators, psychologists for emotional and mental health support, dietitians, physical therapists, are just some of the members you might meet. And they're really there to support you, provide education to you and your support team and your family about the process, the journey, and sort of what you'll be experiencing and what to anticipate. And they'll also advise our patients and our families on how to really kind of be in the best possible health for this journey and for this successful transplant. There are times when someone will go through an evaluation and will not recommend a transplant. And occasionally we have patients that are just simply too ill to go through the procedure and have a reasonable recovery. It's still a lot to take a body through a large surgery and then ask them to recover well on a bunch of medicines. Sometimes patients have severe diseases of other organs. So kidneys, lung, other things may be failing. And then just fixing the heart or the lung alone will not be enough. With that regard, is certainly in heart transplant, there are sometimes options for multi-organ transplant, but it's still not the norm. Substance use, tobacco smoke, alcohol, or other disorders are something that we look at very closely because we really do, just as Charlie mentioned, want people to be good stewards of organs. We want them to do well, and we don't want behaviors that might jeopardize their health, their recovery, or even interfere with other medications. And then back to kind of it takes a village. Just like it takes a village on the part of our medical and our healthcare team, it takes a village at home to help really have our patients and families recover. And so we work with our social workers and our families to make sure that they have a really good support system in place so that our patients who are going through transplant can focus on their recovery. They have all the support they need to really do well with that and get back to that really good quality of life that they want and deserve. There are some organ-specific things that sometimes come up in the evaluation. Active cancer is common to most transplant situations simply because the medicines that we use to treat rejection may actually make cancer worse. And so we don't want to put anyone in a position where they go through a large surgery and we fix one issue, but really cause something else to flare and progress. And that's not really helpful. We talked about advanced disease of other organs. Both heart and lung transplant do have age criteria, and this is a little bit variable. I put some numbers down there, but it might be individualized based on a person's health. They're not kind of taken in isolation. We do look at how robust and how kind of physically strong someone is, recognizing that they may be limited by their heart or their lung condition, but folks that are less frail will often have a better outcome than those who are weakened or frail. And so we'll often recommend therapy, rehabilitation, or other things to kind of address those issues. We talked about substance use. On the lung side, we typically do not consider transplant on patients who are completely bedridden or on critical life support. That's quite rare because it's just a harsh procedure to go through when your body is already fighting their illness at such an advanced stage. And there is sort of a healthy weight of range. So we, somewhere in that normal weight range, not too much on the obese side and certainly not underweight or malnourished. Same types of principles apply in the heart. There's a few other considerations in the heart, which include something called pulmonary hypertension. Again, that's scarring of the blood vessels in the lung. And if that is there, just simply correcting the heart itself will not fix the pulmonary hypertension, and the heart will have to work too hard in order to recover well. And so that would need to be considered as a heart-lung transplant if that is one of the considerations. Same thing on the weight range. And then similarly, some folks who have a heart condition may have vascular disease in other parts. So they may have narrowing of the arteries that supply their brain or to their legs and arms. And if that is really severe and not readily managed with medications or other procedures, your team may think about that carefully to make sure that you don't have a stroke or some other, again, we don't want to cause avoidable serious other complications if we can prevent them, because we want you to recover well. So people go through a wait list, they go through this evaluation. We meet as teams to review everything that a patient may go through during their evaluation period. And then often the team will make a recommendation about either proceeding with transplant and being put on a wait list. They may say, there's a few more things for us to check up on. Let's work on weight, let's work on therapy. And then we'll kind of regroup on the timing of transplant. And then sometimes we find that obviously there is a contraindication or a conflict that would make it hard to get through a transplant safely. But if things are appropriate and the patient and they are ready to go on a transplant wait list and the timing is right, you may go on a wait list. The wait list works a little bit differently for each organ, but the concept is the same, which is that your health information is put into a national database. And those databases are designed so that the sickest patients are at the top of the wait list because they have the least, they're most urgent. They really cannot have their organs sustain them for much longer, and they really need those organs quickly. So on the lung, it depends on your actual lung disease, how much oxygen you're using, different measures of your lung function, and even some of the pressures around your lung in the blood vessels. So those are the types of things that we put in. The heart system was revised in the last couple of years, but it has a similar concept. They have these kind of categories of 1, 2, 3, 4, 5, and 6. And those status ones would be someone who's in the hospital, really is in an ICU or a cardiac care unit because of the severity of their heart condition. As you go down the list, this may be someone who is in the hospital, but requiring kind of complex medicines that require IVs to keep their heart pumping strongly, or other support devices to keep their heart working. And as you go further down the list, these are patients who are maybe stable. They might be outpatient, but still have a severe list, but perhaps not as critical as those folks in the higher, the top tiers. Information about these stages for anyone who is on a wait list or about to go on a wait list can be found at UNOS. I didn't want to go through every single detail, but you can certainly get that in a more patient-friendly manner at the UNOS website, and it's the same around the country. Once you're on the wait list, this information kind of goes into a regional pool of several hundred miles, and so typically our surgical teams are flying, across state lines. And when your blood type matches, the sizes match, and you're in that right criteria range, we'll get offered a donor, and we'll invite the family, the candidate, to come in for surgery. And if everything remains appropriate on the donor side and on the patient's health, we go forward. I know my patients often ask me, how long will I wait for a transplant once you get on that wait list? They're excited to get on the wait list, and then there's that uncertainty of knowing when am I going to get that call? When it'll be time. These are actually data, national data. They come from our registries that are national, that we all contribute information to. And I'll start with the lung, which is over here on the left side. The average wait's a couple months, but it really depends on where that wait list score is. This is this lung allocation score. And so someone with a low score, which is kind of this purple line, might wait a little bit longer because they're more stable, and that's okay. And patients with the highest score, this green kind of 50 to 100, typically folks that are in the hospital, they're going to have a shorter wait that's maybe on the order of weeks, and that's appropriate too, because they're too ill to be safe at home. So the system is doing what it's designed to do, and overall wait times have actually shortened down considerably at most centers around the country. On the heart side, waits have been a little bit longer. As you can see, waits were kind of going up to almost 2 years a few years ago, and now have started to come down. This information is a little bit dependent on blood type. Certain blood types seem to wait a little bit longer, and does not yet take into consideration the new waitlist system. So the waitlist system was launched in 2018, and then of course, we've had this pandemic. And so I think we will be regrouping with some more updated information, hopefully shortly, but I think the anticipation here is that wait times will be going down in heart as well. All righty. Some people ask me, well, what happens if I'm on the wait list, if I get ill, if I get too sick, if I'm in the hospital, what happens? And we kind of touched on that. Your place on the wait list, not will be adjusted. That's what these systems are designed to do. The one caveat is, even though the system is designed so that our sickest patients are prioritized, it does make the transplant a little bit harder on your body. And so if someone is at the point where they are on life support waiting for a transplant, it does prolong the postoperative hospital course. It does unfortunately increase the risk that you might not survive the operation slightly. And it does increase the risk of complications and just things that we have to get through. And so ideally, we kind of find that sweet spot where patients are ill. They clearly would benefit from a transplant, but if we can get people to transplant before they're critically ill, that would be the perfect solution. Nonetheless, the system still works. We're not seeing people that are not recovering from transplant. And so I think the prioritization schemes will likely stay and just get refined to kind of help people get to transplant safely. While someone's on the wait list, what can you do? Exercise is fabulous. So certainly pulmonary and cardiac rehab, hopefully as we emerge from the pandemic and folks get vaccinated, if you've not been able to get back to that, I would ask providers for referrals to go back. Many of the programs set up either virtual programs while the pandemic was due to pandemic conditions, and those hopefully will stay available. And certainly any sort of exercise program is going to be very helpful. We ask that you keep your range. That really does make sense. And the recovery after surgery, I put in the lung numbers, but the same concept applies for heart. And stay up to date on your visit your primary care regularly, and your vaccine, colonoscopies, I think there's an entire session on COVID, so I won't speak too much on it right now, but except to say that, getting you and your family vaccinated while you have a functioning immune system, we think is going to be really important. It may be harder for you to get the benefit of a vaccine to protect you against COVID when your immune system is weakened. And we certainly want to keep our patients as healthy as possible and kind of emerge out of this pandemic without and being able to get back to a good quality of life. So something to kind of talk to you and your family about if you have not already been vaccinated and you're thinking about going through the procedures. And then just, making sure your other health conditions are well controlled. It could be things like diabetes and your blood sugars, any other health things that your team identifies for you, really keeping those well controlled through the process. Hazel, do we want to take any questions? And I know there's a couple in the chat. I can take a second.
Absolutely. We can definitely pop those in. Okay, so we have our first question, which is, I use SRTR to compare lung transplant centers. I find 1-year results. Where can I find data on longer terms? For example, 5 or 10 years.
Perfect. So SRTR used to put out 3-year results as well, although I will say that in the pandemic, they, because everything had to kind of come to an abrupt shift in how we operate, the results might be delayed, and I think they'll hopefully be coming out in July. But there is, I think, from what I understand, even for July, the actual survival statistics may not be fully published simply because I think everyone around the country experienced COVID in different ways and at different times. And so they weren't sure if they would be fair comparing kind of apples to apples from someone in New York in the middle of March 2020 to maybe another part of the country that wasn't experiencing that same condition at the same time. But the national results usually will be from an organ center ways, will be in SRTR. There is on a larger picture, you can get them through some of the UNOS, and or you can get them through ISHLT, the International Society of Heart and Lung Transplant, and those are publicly available. So some of the same stuff that I just showed you a second ago. And you can actually ask your center. So all of the centers should have their own longer term results if you're looking at a couple different centers, and you should advocate and ask, and that's often helpful. But you may find that this year, because of COVID, SRTR was a little bit uncertain as to whether they should be comparing center to center because of the geography and the way it affected people at different times. I think that's the first two. I can see this questions.
Okay, wonderful.
Does that answer the question for the, we just chat in if there, and we can certainly get to it at the end. Oh, impact of COVID on donor lungs. Excellent question. So the donor lungs are all tested for COVID. Certainly for the last year, we took a pause for about 2 to 3 weeks when COVID first came out until we knew we had a good process in place. But LLF and the Maryland teams have been wonderful partners, and we actually take 2 swabs, one from the nose and then one from deep within the lungs. And they are tested rapidly for COVID. And so that is done. And then we have CT scans and x-rays. And so if there is the x-rays and CT scans look healthy, if the screening comes back negative and there's not an obvious risk factor for an exposure to COVID, then we move forward, and that's been really safe. We've been pleasantly happy that we've been able to continue transplanting throughout COVID and not had to delay things because of the concern from the donor side. But it's actually been a very safe process for the past year, and that's generally been our experience around the country as well. One more. Pain meds.
Do you want me to read it for you?
Oh, I can see it. I'll do it. I'll read it out for the team, for the group. If a person's on pain management for something like fibromyalgia, how can they be listed? He was told he has to be off the medicine for 6 months, but when he tries to decrease his meds, he has so much pain, and his options up to 5 liters. It's a great question. I may come back in the open session because some of this has to be so individualized. But a nice thing to try and do is see if there is a referral or a pain management team that can help with that piece. And also sometimes ask at different centers what kind of support teams they have, because each center is a little bit different in terms of their collaborative support for things like chronic pain, even substance use, mental health support things. So it's certainly something to ask about, and making sure they have a really good collaborative health team to kind of help with the person's individual conditions. So I think I'm happy to take that as well after the session and to get some of those individual details. Okay, anything else? Is there anyone else that's open? We'll keep
Dr. Shaw, we
going.
had a question on the chat. And
Oh, okay.
the question was specific to, are there any plans to institute the organ care system at UMMC or Johns Hopkins?
Organ care system is available at Johns Hopkins. And I'll talk about that in a little bit towards the end of the talk. So I'll hold your thought there. And then there's a couple more things. The wait time after radiation, a small lung nodule that was inconclusive. Can I come back to that one at the end? Because that's a little bit of a specific question, and we'll definitely come back to that one for Trish. Let me just scroll through real quick. Caregiver support, some research, and okay, perfect. Let me go take the caregiver one, and then we'll come back to the research one at the end as well, because that's kind of, I have a slide on that. Just for the caregivers. So this is a great question, and it really depends on what that full-time support looks like based on the patient's condition. So I can speak for our center. We often say, yes, for the first 3 months of the patient's discharge, there should be a primary caregiver who's available and someone as backup, because you just don't know what life is going to bring your way. And sometimes, your primary caregiver may have a health issue or another emergency, or have another commitment that, they're a parent and they have kids. And so you may need a backup so that you're not shouldering all of the burden of caregiving on one person. But typically I would, at our center, we'll typically say about 3 months. And it's different for everyone. So some patients need help with meals, doing grocery runs. Others will need more help just kind of organizing their medication list, because that's just not what they are strong at. Others will go home on IVs, or may have other kind of equipment, and they need help with some of that physical piece. And then for everyone, I think that some of that support is not only just kind of those day-to-day tasks, but also being the advocate and a second pair of eyes and ears. So that as a patient, while you're focusing on your recovery, it may be that your support says, hey, you don't quite look the same as you did yesterday. Let's give the team a call. Let's make sure everything's going okay. And so if there's that period of uncertainty, having someone to be a sounding board, or feeling like they're empowered to just reach out to the team, get reassurance that everything is okay, and obviously bring to attention if there is something that needs to be taken care of, can often be the best role of a caregiver, and the one that we find really helpful in terms of the partnership with the healthcare team, that even if the patient's not sure whether they should reach out about a question, having that caregiver reach out and say, hey, I'm worried about this, or I was unsure about this medicine, we know to follow up with them. We can definitely talk more about that too, because it's certainly an important and complex topic, and each family has to figure out that caregiving piece with what works for their specific situation. So we know that everyone's family is different and their commitments may be different. And so we want to make sure that we can provide the support needed. All right, I'm going to come back to those research questions. I'll come back to the nodule question as well, just so we can make sure we get through the talk, and hopefully we'll get to all of those questions at the end as well. All right. We talked about weight already. We talked about the importance of exercise. This is just one of a research manuscript that came out just on the lung transplant side. They just kind of showed that how far you can walk actually affects how your recovery is after transplant, regardless of your disease, what your lung function was, what your age was. It was just sort of the concept of why that physical piece is so important, even though it may be difficult when you're heart doesn't work well or when your lungs don't work well and you're tired and you can't breathe well. Alrighty, so let's talk about some of the successes and some of the challenges after transplant. This is just our lung transplant survivals to kind of get to one of our patients, but this is overall, and this is publicly available. If you go to these ISHLT websites, they have heart and lung transplant slides as well as publications available on these, and they put them out every year. Overall, things are improving for the lung transplant field if you look at where things were at the red line compared to the blue line. But the average survival is about 7 years, but it's, again, big range of outcomes. So we are doing our best to kind of protect those lungs for as long as we can. And obviously we've followed some people out, as I said, to their 20, 25 years, and we'd love to see everyone kind of get out to those longer term survivals. This is the heart transplant, both heart, adult and pediatric combined. Again, survivals are a little bit longer. The first year is that trickiest part, and then things do seem to settle out, and we'll talk about what happens in that piece. After you have your transplant, I didn't talk too much about the surgery, but the surgery is usually a good 6 to 8 hours surgery. You should expect to be in the hospital for a couple weeks, and then that really then individualized basis on your recovery as to when you go home and when you're feeling well enough to finish the recovery at home. Once you are home, the team will follow you for life. We make sure that your new heart and your lungs are working well. We screen for rejection, side effects of medicines, look for infections and complications. And we also kind of want you to work with us and your primary care team to make sure that the rest of you stays healthy and really gets the best quality and outcome from the transplant. We touched on this a little bit, that because your organ is foreign to your body, your immune system's natural reaction to say, nope, get it out of here, it's not mine. And so we have to use anti-rejection medicines for life to help slow down and control the body's natural tendency to use rejection. And so how much you'll be on depends on the organ that you're on. So the lung patients tend to be on longer and higher doses of immunosuppression. Their lungs are open to the air. There's a whole lot of immune cells because the lung is kind of designed to keep germs out and fight off pneumonias and viruses and all of that. So there's cells in your lung that are just ready to kind of jump on things. And then of course, when it's a foreign lung and you get a little cold, sometimes your immune system kind of forgets that it needs to just fight off the cold and not attack the actual lung itself. And so we do have to use higher doses of rejection medicines. The heart will still need to be on rejection medicine for life, but perhaps they can lower their doses and not be on quite so much for so long. The heart is kind of isolated from everything else. And once those initial few months kind of settle out, things tend to go a little bit smoother. We touched on the medicines being very, very vital and so key to surviving a transplant, but they can have side effects, including kidney problems. The steroids can cause diabetes, can cause osteoporosis. When you weaken your immune system, you do unfortunately also reduce down the cells that naturally protect against cancer. So we often encourage our patients to be really, really vigilant about screening for cancer, staying on top of their mammograms, their colonoscopies. We send you to a dermatologist, all things that we can do to make sure we stay on top of this and try not to have other complications. And you'll often be asked to get blood work and other tests to look for these types of side effects. Just a few things that are unique to each organ. So on the lung side, you can have acute rejection, and especially in that first year after transplant, and happens in probably about a third of patients. You may not have any symptoms from it. It's something that we will screen for at every visit. We'll look at your lung function through a kind of a handheld or a formal spirometer. Periodically in the first year, you'll actually have a bronchoscopy, and we'll take a small piece of the lung tissue to look at it under a microscope. And we'll do blood tests to look and see if your body's making any sort of antibody or other sort of reaction against your donor. So if we see it, we might adjust your medicines or even have you come in to the hospital for something intravenous, depending on the severity and how much it's affecting you. These are usually very treatable. So these episodes happen, they usually kind of move on from them. But over the long term, one of the things that we all try to be mindful of is the fact that there can be something called chronic rejection. This is more of a scarring process that isn't often seen on biopsy, but can happen over time. And it's really what limits the long-term survival and the long-term longevity of a lung transplant. And it kind of goes back to the fact that we never completely fool the body in that the lungs are always vulnerable to some rejection. And that this over time, even sort of low levels of immune activity can lead to scarring in that airway. It happens in about 50% of our patients, but half our patients will have it within 5 years. But it doesn't necessarily mean that the lungs are going to suddenly stop working. So I think a lot of folks get quite frightened when they hear that word chronic rejection, because we obviously would prefer it not happen at all. But sometimes we can have a little bit of chronic rejection and things can actually level out. And I've had patients that developed chronic rejection and then stayed fine for the next 5 or 10 years. So it's not that it can't be halted, but there are certainly sometimes where it does progress no matter what we do. And so we do our best to try and look for things that can trigger it and treat them and prevent it as much as possible. So in the lung, that often is infections. So even before COVID, masking was a part of our lung transplant families' lives, because we do try to keep it, the flu and other common colds, we do try to protect you from that, not just because it makes you ill in the setting, but because it can actually contribute to this rejection process. Other things, heartburn and acid reflux, some of that can actually get up and go into your lungs. Anything else that you're exposed to in the environment, right? Cigarette smoke or other kind of irritants. And then often those episodes of acute rejection that we talked about can actually put you at risk for chronic rejection if they're not treated in a timely manner. Just an example of certain things. So sometimes, if someone has really bad reflux, we can actually correct it and we can actually improve their lung function. There are treatments like azithromycin or other anti-inflammatories that can actually help prevent and protect against chronic rejection. And in general, the sooner we can kind of address those issues, the better we are at preventing chronic rejection. You've heard me talk a little about infections in the lung because it's kind of a two-hit. You are taking medicines that sort of make your body less able to fight off bacteria and molds and viruses. And then obviously your lungs are exposed to the environment. And so that also makes a big deal. And so we have all become experts in how to avoid exposure to infection, unfortunately, this year with the pandemic. And so those same precautions in terms of wearing a mask, calling your team if you have any symptoms, avoiding people that are known or to be actively sick, many of these will actually were in place for our lung patients before COVID. And it does not mean that you don't have to see your family or be in complete isolation, but that there's some common sense about trying to avoid people that are knowingly infected and trying to make sure that everyone does the best to keep each other healthy. So I think that's been a learning experience for the entire world this year on that piece. Just going on to heart. Also, again, in those first few months, acute rejection can be common. A little bit on the earlier side than in the lung transplant population. Small subset, about 15-20% will have an episode. Again, these things may not have symptoms. In fact, the teams really would rather figure this out before you're symptomatic, but you might be lightheaded or short of breath, or you might have not a decrease in PFTs, take that away. You might have an adjustment in your blood pressure. And if it's severe, it actually can cause a little bit of what we call like a shock picture where your heart is just not able to squeeze properly and suddenly you can't maintain a good blood pressure. So the cardiac teams will actually look for this very closely. They will do a catheterization and often they'll biopsy a piece of that heart muscle, often in the, once or twice, several times a month in those first months, and then maybe even monthly that first year. And then it gradually tapers off as that risk kind of goes down. There's also really some nice blood tests that are become more cutting edge, but really now commercially available to help screen for rejection and are perhaps a little bit less invasive than having to do a biopsy. And so that is being kind of brought into the fold of how we think about and screen for rejection. And just like the lung, again, if we see this, we often may need to adjust the rejection medicines or consider intravenous therapy just to kind of get that inflammation calmed down quickly. Both of these processes are immune processes. So what we see on the biopsy, I forgot to mention, is that we're seeing immune cells. Your lymphocytes and your white blood cells are kind of in these areas of your lung or your heart muscle where there really shouldn't be so many. And that's kind of the signal to the team and the pathologist that there's a rejection process going on when they look under the microscope. Just like you can get a scarring process in the lung with chronic rejection, In the heart, this is called cardiac allograft vasculopathy. And it's sort of a scarring and narrowing of the coronary arteries. And it, just like little hearts last a little bit longer, that this process also occurs a little bit later. So about half our patients in heart get it about 10 years into their transplant, as opposed to kind of that 5-year mark in lung. And it's a narrowing of blood vessels. So it's a little bit different from your typical coronary atherosclerosis, that what we commonly think of as the risk factor for a heart attack, where you can get these kind of build up and sort of bubbles of cholesterol and plaque that narrow the blood vessel in sort of little points. Typically in the transplant side, it's a little bit all over, where the blood vessel is kind of getting narrow, and it's a mix of scar, which is fibrosis. There's some plaque, which is kind of cholesterol based, and then ultimately it still gets narrow. And the long-term risk to the heart is similar to what would happen with a cholesterol plaque, which is that you just don't get good blood supply. Patients may not always have angina or chest pain because we don't have good nerves after the surgery. And so a lot of times the cardiac team will screen for this either with stress tests or cardiac catheterizations. And their mainstay for preventing this is to focus on having really good cholesterol control. So a statin will probably be part of your treatment regimen after transplant. They may kind of modify your rejection medicines to ones that are tailored towards reducing kind of the scarring process. And then if there's something that is kind of a small area or something that's more acute, they may put a stent just like you would if you were having a coronary process and you needed a stent to kind of open up an area of that coronary artery. Just on the heart side, a couple other things to mention. Early after transplant, there can be some rhythm disturbances, just because, again, you're reconnecting the heart to the blood vessels, and as the blood flows, it can cause a little bit of scar tissue as it's healing, and that can cause some rhythm issues. Those typically settle out after transplant. The biopsy procedure can sometimes affect the valve in the heart that it has to go through to get to the heart muscle. Rare, but it's a known complication that they need to keep attention for. And then I mentioned this a little bit, but there is some risk of cancer over the decade or so as you're on these medicines. And so some of them are the routine things that everyone's at risk for: heart, breast cancer, colon cancer. But there are certain things that seem to be more common in transplant patients that includes skin cancer and a certain type of blood cell cancer, lymphoma. And so we may often do some blood work or have patients see a dermatologist to look for these and really try to prevent and address them before they become an issue. And so just something to be aware of, and your teams will talk to you about that in your follow-up. That said, lots to do to stay healthy and active. Certainly exercise, taking your medicines, staying healthy with regards to weight and nutrition, paying attention to your lung function, your symptoms. Our pulmonary patients actually go home with a mini home spirometer to check their lung function. But on the heart side, watching your heart rate and your blood pressure, and just calling the transplant center. If anything changes, just reaching out and saying, hey, something's different from my baseline, so that we can help you understand what's going on and feel better. But with that, before I get to the research, really the goal is to get people back to a good quality of life. And we always are most humbled and really feel a lot of joy when we see patients and they bring in their pictures of their grandkids or getting back to those, to their work or their life milestones or traveling, all the things that bring us joy and meaning in life. And really our goal is to get our families and our patients back to that. Couple of things I think people asked about research. Let me just go into the Q&A real quick so I can make sure to address the specific questions. Heart research in the near term and kind of where it will, okay, perfect, where it'll roll out. And we'll talk about that cancer piece as well, actually. Hazel, how are we doing on time?
Yeah, I was just going to check in. We're at 9:55, so we have about 3 more minutes.
Perfect. Okay. Well, this is actually the end of, we'll touch on the research and we'll get that question answered too. And then I'll stay in the chat room for any other questions that have come up in the second half of the talk. So a lot of exciting research has been happening, and I'll talk about 2 things. The first is on the lung side, which is just, you'll see this has been happening over the past decade, but it's kind of here in real time now, which is donor lung preservation. So we can take lungs out of a body, and instead of just shipping them over on ice, we can put them in a little bubble in a circuit. We can provide them with appropriate oxygen and fluids to kind of keep them healthy. And really, that's available to kind of look at lungs that might not otherwise been used, or that someone was not sure if they were the right lungs for this candidate, and really make sure that they are the perfect lung before we put them into someone's and accept them. So you'll hear about that with both the organ care system that someone asked about, but then there's a couple other machines and companies that have this sort of a setup. And so they are in use and available. And then really on the science side of that, people are looking at treating the lung. So if there's something in the lung that we can give to even make them work better, or to prevent rejection or early changes in the lung and help them recover more quickly, if we can do that while they're en route, even before they get into that candidate's body, that would be wonderful. And so that's kind of where the science cutting edge is right now, is saying, well, we have a system that works, but can we make it even better by helping these lungs really stay healthy and not get damaged at all in that surgical process. On the heart side, I think I want to mention a little bit about where a lot of work has happened over the last 5 years, which is not moving away, but being able to actually detect injury even before we see it on a biopsy or those more invasive tests. And it involves really looking at the genes that are and the DNA that's being kind of released into the blood from that donor heart. So we can compare recipient DNA from donor DNA, and we can actually tell what's coming from the donor. And if it's leaking into the blood, we know that there's something that brings that we need to take attention from. And so a lot of exciting work is happening to use that test, not only because it's less invasive, but it may actually pick up things more sensitively and more quickly than you might with a biopsy. So you may hear about that from your team, about various types of blood tests to screen for injury, take care of things before they get to be a little bit more severe. And that's really a large focus of research that I want to touch on, and lots more, but in the interest of time, I'll highlight those two. And we'll conclude. Really, this can be a great life-saving treatment for people with advanced lung or heart disease. We want to make sure you go through an evaluation carefully. And it does require lifelong care, and your teams are really here to help you have the best possible quality, quantity of life after the transplant. And just some websites as well as my contact information right here. So feel free to reach out to your centers, to the national kind of organizations, or us if there are questions that you have as you go through the journey. And I think certainly a forum like TRIO is wonderful, especially this year, and more than any year when it's been such an isolating year to not be able to talk to people. Really take the time to reach out to folks and see what their experiences are like, because it's hard to know what you're going to go through unless you've actually been through it, no matter, so really take advantage of those opportunities to connect with people. Hazel, I think there was one more individual had a question about a lung nodule. Can I take it in the chat room or in this forum here?
Yeah, let me ask you to take it in the chat room. And right now, to all the participants, I have just put into the chat box the general meeting room link. So first and foremost, thank you again, Dr. Polyshaw, for your time and insights. Our next sessions will begin at 10:15 Eastern Standard Time. Please check your email for the correct Zoom link. Again, for those who want to connect with other participants and to continue the conversations with Dr. Shaw, please visit the general meeting room, which is now going to be open. You can log in using the link provided in the chat box. This room again will be open until 12 p.m. Eastern Standard Time, and please use it to interact with and make connections with other attendees. One more note, please visit the TRIO Maryland website, which is triomaryland.org, to learn more about their organization and more information about them, their sponsors, who make this event possible each year. And we will see you at our next session. Thank you, Dr. Shaw.